Next we have Dr. Surbhi Kapoor, and she'll be talking on the types of intraocular lenses.
Good morning, everyone. So, I'll be talking about the type of intraocular lenses. Let's have a brief insight into the history of the IOL. So, this is a picture of Sir Harold Redley. He was a ophthalmologist during the time of World War II and during the Battle of Britain. He had this discovery that the pilots who were flying and were coming to him with an eye injury usually have a inert material in the eye, which is the canopy of the helicopter or the fighter plane which was made. It was made up of PMMA, and in that PMMA it was inert and it usually stayed in the eye for a longer period. So years later, when he was operating and he was doing a cataract surgery, one of his residents just asked him that what is the fun of doing a cataract surgery if we are not implanting anything? So at that time, he was like, Eureka, we had something. So this thought came to his mind, and he thought of implanting a PMMA IOL into the eye. So we have different generations, all thanks to Sir Ridley. So depending upon the years, we have Ridley PC IOL, which was implanted in the year 1949, 1954, and later on. So the first generation of IOLs and the first generation that was invented had PMMA, and the latest we have the 7th and the 8th generation, which include the premium and the phakic IOLs. So based now another classification which is based upon the sites of fixation. So we have the anterior chamber and the iris supported. Then we have based upon the IOL material, on the focality, based upon the phakic refractive IOLs, sphericity and toricity. We have special function IOLs, and also we have the edge finish. So I'll be discussing one by one everything, just a brief insight into each, and how to select a patient and to decide which IOL has to be implanted in which patient. So moving upon the site of fixation. So we have the anterior chamber IOLs implanted in the anterior chambers, not done routinely used days as we have better options. Increases chances of pseudophakic bullous keratopathy, and also there can be pupillary block glaucoma if a iridectomy is not done. So chances of pseudophakic bullous keratopathy does not make it a very good option. We have the iris claw lens again implanted in the anterior chamber. Also it can be implanted retropupillary. And then we have the ciliary sulcus IOL. If we have a good capsular excess RAM and there is a posterior capsular rent, we can always implant a ciliary sulcus IOL that is good enough as a capsular bag. Good enough, not like perfect, but still close to it. Moving on to the IOL material, we have PMMA. PMMA is implanted. It is a rigid IOL, usually implanted in patients undergoing small incision cataract surgery or extracapsular cataract surgery. Then we have a foldable IOL. In case of foldable IOL, these are usually implanted in phacoemulsification surgeries, which we all are witnessing these days. Then for like very, very small incisions, phaconet surgeries, we have the rollable IOLs that can be implanted, ultra thin rollable IOLs. Example like AcrySmart is available as a rollable IOL. Moving on, just quoting Celine Dion's song Near, Far, Wherever You Are. So for a great range of vision, we have the monofocal and the multifocal. So monofocal IOLs are usually focused on if we need a best possible distance vision or a best possible near vision. For example, if your patient is a hiker, so he needs a better distance vision as compared to a near vision. So we can have a monofocal distant vision IOL for him. If he is a goldsmith and he has more of near work to be done, then we can always implant that near vision monofocal IOL. It has the lowest side effect profile when it comes to focality, since they don't split light. Availables are IHANS and Ray 1 EMV. In multifocal, there is more spectacle independence and a great range of vision. Sharp vision at multiple distances has its trade-offs due to the splitting of the light, and thus the patient complains of more glare and halos. So multifocals. Multifocal can be divided into refractive IOLs and diffractive IOLs. Refractive IOLs have excellent intermediate and distance vision, and the diffractive, they have excellent reading vision but a very good distant vision and a fair intermediate vision. The refractive, as you can see in the picture that on the right side, so we have various zones that determine whether distance, near, and again distance. So it is very pupillary dependent. So that does not make it a very good choice. Diffractive, having a anterior refractive surface and a posterior diffractive surface, less dependent upon the pupil but gives a fair intermediate vision. Commonly seen multifocal IOLs that we use are Restore, Silence, Technis MF, and Technis Symphony. Moving on to EDOF lenses, that is the extended depth of focus IOLs. So we see at various distances. Strong intermediate and distance vision is there, plus there's a good near vision and few visual side effects. Now, for example, if you are watching a match or if you are seeing any football match or something, but you want near vision, intermediate as well as distant vision, so extended depth of focus IOLs are good. Examples are Symphony Optic Blue and the non-diffractive Vivity types. Moving on to the phakic refractive IOLs. So phakic refractive IOLs you can implant in patients usually in the high myopic patients, for example from -5 to -20 diopters. They can also be implanted in posterior chamber circles, angle supported and iris supported. So the posterior chamber one that we are routinely using is the ICL by Star Surgical and the PRL by IVI Medinum. Then we have Novita, that is an angle supported PRL, and the iris supported PRL, which is the Artisan lens. Moving on to the toric IOLs. These are astigmatism correcting IOLs used at the time of cataract surgery, and they reduce post-operative astigmatism. The patient usually has a regular astigmatism with good vision potential and without any coexistent ocular pathology, thus enjoying in distortion-free distant vision. So you can see those markings on the toric IOL. So that vertical markings on the near the haptics. So that can help you identify that it's a toric IOL, and based upon the astigmatism or the pre-recorded astigmatism that is present and the angle at which it has to be implanted, it has to be aligned with those markings. So this is a good, just toric marking and everything will be another lecture, or it is going to take a lot of time. So you all can always visit this very good article in the Indian Journal of Ophthalmology present on the internet on toric IOL lenses, where you can have a brief insight into the how toric IOLs work. Plus, this is just a list of the available toric IOLs that are present. Moving on to aspheric IOLs. Now, what happens is if the peripheral and the central rays do not meet at one point, so we have not a very good image that is formed. So spheric IOL, so normally cornea has positive sphericity, cornea has a positive sphericity and the lens has a negative sphericity. But as the person ages, cornea, the lens also has a positive sphericity that is present. So we are having a very dull image that is usually present. Now we have the aspheric IOLs, which does not have that sphericity, and thus improving the quality of the vision that is present. Now this is just a screenshot from one of the very famous ophthalmologists, Dr. Uday Devgan. We all must be watching the video of his. So he had this understanding aspheric IOLs. So prospective cataract patient, if there is no prior corneal refractive surgery, but there is a likelihood of IOL decentration, we can have aspheric IOLs with 0 spherical aberrations. Then if IOLs is not likely to decenter, but the depth of field is critical for the patient, then also we can implant the same. But if the image quality is critical to the patient, then we have to think about a negative spherical aberrative lens. That is the aspheric lens. Also, we have special function IOLs. So post-trauma, if there is iris loss, then we can always implant the NRIDIA IOL. Then we have this implantable miniature IOL, usually used in the patients who have retinitis pigmentosa, or the patients who have ARMD at an advanced stage. What it does is it helps to focus light on a wider area in the central region, and thus the patient is able to perceive the image. Then we have the piggyback IOLs, high power, like in small hyperopic eyes in which a large power is required. So what happens is the quality of the image is distorted. Once the quality of the image is distorted, then the patient is not very satisfied. So this is just piggybacking an IOL. So there is already an IOL, and then we calculate the power and we implant another IOL just over it. So there are certain drawbacks, as the patient can always land into angle closure or something. And then we have the smart yellow IOLs or the blue blocking IOLs, which gives a distortion-free image. Concluding by just remembering one thing, that we always should use the right IOL for the right patient. Always inquire about the job profile of the patient, what the patient requires after a cataract surgery, and then you will have a happy patient going home and obviously revisiting you for another eye of his. Thank you.